We will discuss about the diseases of esophagus, and in the previous lecture we have covered about the salivary gland tumors, the benign and the malignant, so you can go through that video as well. So we will go through some of the histological features of GIT, and then we will discuss about the esophageal disorders. First of all, the epithelium of the GIT is for the oral cavity and esophagus, it's squamous epithelium, okay, and for the stomach and small large intestine, it's simple columnar epithelium. In the histological perspective, we can see the mucosa, and underlying mucosa is submucosa, and the tunica muscularis, the muscle layer, and the outermost layer is serosa. Okay, there are several nerve plexus that are present in these layers. The nerve plexus present in the submucosa is known as the Meissner's plexus, and that present in the tunica muscularis is the Orbach's or mesenteric plexus of the nerves. These nerve plexes are present in the walls of the GIT as to contract and to regulate the peristaltic movements. One more thing I want to highlight, that some mucosa is absent in the gallbladder because gallbladder is also part of digestive organs, and serosa is absent in esophagus. In the esophageal walls you cannot see the serosa, okay, and in the gallbladder we cannot see the submucosa. So mucosa, submucosa, muscularis, and the serosa. Talking about the nerve plexus, these nerve plexus contains ganglion cells, okay, and these ganglion cells are responsible for the movement and motility of the GIT. But there is a disease known as aganglionosis. It means that there is absence of ganglion cells. This is a very famous disease known as the Hirschsprung's disease, and in the Hirschsprung's disease you can see the absence of ganglion cells. Why is that so? It is because the failure of migration of the neural crest cells. It means that during the formation of the primitive streak, when you go through the embryology, you can see that there is failure of migration of neural crest cells, and it results in the absence of the ganglion cells in the GIT. So you can see here that it's the normal colon and rectum, while it's the Hirschsprung's disease colon and rectum. Here you can see that there is absence of ganglion cells, and in that part there is shrunken rectum. So it means that the children cannot pass the stools, or after the birth the baby or neonate cannot pass the meconium after the birth, okay. And in the rest of the GIT you can see the yellow dots, it represents the nerves or neurons or ganglion cells, but in this part, the shrunken part of the rectum, you cannot see the ganglion cells. So there is the Hirschsprung's disease, and the children screams due to the pain, and they cannot pass the meconium or the stools after birth. One more thing here worth mentioning is that the pacemaker cells of GIT, the pacemaker cells are those cells that are responsible for generating and propagating the electrical waves, so the peristalsis can occur. The cells of Cajal are responsible for the GIT motility, and cells of Cajal, a mutation results in the GIST. It means that gastrointestinal stromal tumors can occur when there is a mutation in the cells of Cajal. So it's worth mentioning here because our topic is GIT disorders. This was like a brief introduction. Let's begin with the esophageal disorders. First of all, the length of esophagus is 25 centimeters. And what about the physiology? When we ingest a bolus of food, it is passed through the movement of peristalsis. For example, here is the bolus. The proximal part of the esophagus will constrict or contract, and the distal part will relax or dilate as to pass the food. The constriction will be occurring due to the acetylcholine. Okay, it's a neurotransmitter, and dilation is due to the nitric oxide and vasoactive intestinal peptide. These are responsible for dilating the esophagus, and there are several diseases that can occur due to dysfunction of these neurotransmitters or these hormones or chemicals. There was a worth mentioning question here is that what is the precursor for nitric oxide, from where the nitric oxide is coming from? It's arginine. Arginine is an amino acid from which the nitric oxide is being formed. So it's worth learning or memorizing. First disease of the esophagus is Achalasia cardia. And Achalasia cardia is nothing but the failure to pass liquids. Okay, it's the failure to pass the liquids due to the stenosis of the lower esophageal sphincter. And the causes of the Achalasia cardia is loss of inhibitory neurons. Why I'm saying that inhibitory neurons are lost, it's because that the nitric oxide and the vasoactive intestinal peptide cannot work. It means that dilation cannot occur. Okay, but acetylcholine is still functioning, so constriction will be there. Okay, constriction will be there, but dilation part is not working, so it means that the constriction will occur in any part of the esophagus, but most commonly in achalasia cardia we can see constriction in the lower esophageal sphincter. Okay, the sphincter, cardiac sphincter, you can say that because it's achalasia cardia. So cardiac sphincter of the esophagus is constricted. What are the causes for achalasia cardia? There are primary causes. Most of the cases are idiopathic, that we do not know the cause. But secondary, it can be either infection or diabetes. Infection is due to some viruses. You can say that Trypanosoma cruzi. It's a very important agent that causes this disease, because Trypanosoma cruzi also responsible for the Chagas disease. The Chagas disease is also known as American trypanosomiasis, and the result for that is the achalasia cardia. It's the constriction or the stenosis of the lower esophageal sphincter. Also the herpes simplex virus, these both can cause the achalasia cardial symptoms. The second most important cause is the diabetes. As you know that diabetes has many effect on the nerves. We call it diabetic neuropathy, and when the nerves are not working, it means that inhibitory neurons are lost. Okay, neurons are also nerves, so these are lost and acetylcholine is still there, so it results in the stenosis. What a patient presents with clinical symptoms, it's dysphagia. Dysphagia means that there is difficulty in swallowing, but the most important thing here to mention is that the liquids are more difficult to swallow, to pass, but solid can. Why is that so? It means that, for example, when we ingest a bolus of food, due to its pressure, it can open that stenotic thing, and it can pass onward. But when there is liquid has droplets, right? So these droplets do not create such pressure as to open that stenosis. But if solid is hard to pass, it's esophageal cancer. And when liquid cannot pass, it's achalasia cardia. You can compare the healthy and achalasia cardia esophagus, that there is a stenosis in the lower esophageal sphincter, and this sphincter cannot relax and the contents cannot be moved forward. Talking about diagnostic modality is the barium swallow study. It's the technique when the patient ingests barium, and barium is a liquid chemical. And when the patient is ingesting that barium, and we can have an x-ray of that, and barium reflects light, so it becomes lighter than the surrounding. As you can see that it's barium, we can see it more lighter in color as the surrounding, and it results in the bird's beak deformity, and it's a very famous a term that we use in pathology, that it's bird beak. As you can see that lower esophageal sphincter is giving you that bird's beak deformity appearance. Okay, the second is the esophageal manometry technique, in which we estimate the pressure inside the esophagus. And what would you expect, that pressure would be low or high? The pressure would obviously be high because the contents are trapped here. Talking about the treatment is that, and as I have mentioned, that acetylcholine, that was a constrictor that was responsible for contraction, is still there. It's not defective, but the nitric oxide and VIP are effective. Acetylcholine is there, so there is an injection known as the botulinum toxin injection. It's given, and it results in the inhibition of the acetylcholine. When acetylcholine is inhibited, so the contraction is inhibited, so the food can pass, or liquid can pass, more specific. And botulinum toxin is an injection. Apart from that, we can have a botulinum infection by obtaining canned food, the food that are preserved and they are canned, present in cans. So the botulinum can also be obtained from there. And surgery is one of the most effective way for the treatment of Achalasia cardia. The name is the Heller's myotomy. Heller's myotomy, its myotomy means that there is some cutting of the muscles. The lower esophageal sphincter is cut, and the contraction is released so that the treatment can occur. Okay, when we are talking about achalasia cardia, there is a syndrome known as the Allgrove syndrome, also known as the triple A syndrome. Here, the triple A, the triad of A is present, and achalasia cardia is one of them. So why not? Why not discuss this? First, it's the triad of syndrome. It means that triad, three things are present in this syndrome. First, A is the achalasia cardia we have mentioned. The second is the adrenal insufficiency, okay, and the third is the alachremia. It means that lacrimal glands are not functioning, and it's due to what gene? As the AAA is present, so AAAS gene mutation. It's very simple to memorize it, okay. The three A's are present and AAAS gene mutation is present, so it's the Allgrove syndrome, and these symptoms grow with time. These symptoms become worse with passing time. Having said that, we can move on towards the second disease, is the esophagitis. As you know that itis is term used for inflammation. It's the inflammation of esophagus, and there are several causes that why inflammation is present there. First is the chemicals, the second is reflux, and the third is infective, and the fourth is the eosinophilic esophagitis. So let's discuss the first, it's chemical. What chemicals are responsible for the inflammation of esophagus? These are bisphosphonates. There is a bit of touch of pharmacology here. Bisphosphonates are chemicals that are used in the treatment of osteoporosis. Osteoporosis is a disease that most common in the women over the age of 50 years, and it's the there is a porous condition of the bones. The bone became porous and density is reduced, but this is not for our topic for today. But bisphosphonates are used for the women who suffer from osteoporosis, and whenever the physician prescribe you bisphosphonates, they also mention that never lay down for 30 minutes after consuming the bisphosphonate chemicals, because they can cause the inflammation in the esophagus. The second is the reflux. Reflux can be acute and chronic. More often, we all suffer from the reflux when we have a tea or coffee or small amount of alcohol. We can suffer from reflux, but acute is okay. But chronic reflux can lead to GERD, and GERD is the gastroesophageal reflux disease, and ultimately it leads to Barrett's esophagus. But Barrett's esophagus we'll discuss in the next lecture. But you believe me that reflux is also one of the cause for the esophagitis. Okay, the third is the infective esophagitis. Infection can be due to various it can be due to fungus, it can be due to viruses. Okay, the first is the fungal infection. The most common fungus responsible for the infective esophagitis is the Candida albicans. Okay, Candida albicans causes the infective esophagitis, and you can see grossly, we can see membranes. Okay, we can see chalky white appearance or curdy white appearance inside the esophagus. It's the endoscopy, and there is formation of pseudomembranes. Okay, these are pseudomembranes you can see, and in microscopically view we can see the candida as pseudohyphae. These are the hyphae of the Candida albicans, and in the microscopical view we can see the hyphae. Whenever there is candida infection, we always see curdy plaques, curdy or to yellowish whitish plaques. Either it's in the oral cavity or in the cervix, the cervical infection of the candida. But we always see the curdy plaques, and in this esophagitis, we can see the pseudomembrane and the pseudohyphae are present. I hope this is clear that this description, whenever it comes in your exams, you can identify that it's the candida infection of anything, like it can be of oral cavity, it can be of cervix, and in this lecture we are discussing about the esophagus. The second virus is the cytomegalovirus, it's CMV, esophagitis, and the most common description for that is the formation of shallow ulcers in the middle to lower esophagus. And the shallow ulcers means that these ulcers are not deep, okay, and these are shallow. But most important is the microscopic description of CMV. In CMV, we can see a cell. Okay, this is a large cell, and it has owled eye appearance. The eyes or the nuclei are like owl eye appearance. It's the most common description of CMV from head to toe. Wherever there is CMV infection, you can always see this microscopic slide or microscopic description. Owl eye appearance, and with basophilic inclusions inside that. These inclusions are basophilic, you can see here. And these inclusions are not only intranuclear, but these are also intracytoplasmic inclusions. Okay, these are present inside the cytoplasm as well as inside the nucleus. And grossly we can see the shallow ulcers. These are shallow ulcers inside the esophageal wall. Last but not the least is the herpes simplex esophagitis. Herpes is very common for the responsible for esophagitis, and the difference between the CMV and herpes is that CMV causes the shallow ulcers, but the herpes causes punched out ulcers. It means that the ulcers are punched out. They are like more punching out of the surface. You can see here it's very prominent in the diagram that these are punched out ulcers. It's very specific for herpes, and there are three conditions you need to remember in microscopic examinations: that the cells are multinucleated. I will zoom it for you that they are multinucleated cell, not one but two or multiple nuclei are present inside the cell. Okay, multinucleation is there. Nuclear inclusions, inside the nucleus there can be various inclusions. Okay, we can see, And third is the margination of chromatin. It means that the chromatin material is pushed towards the edge of the nucleus or edge of the cell, so the edges are more dark than the cytoplasm. These three conditions are very specific for herpes. First is the punched out ulcers, second the multinucleation of cells, third is the nuclear inclusions, and fourth is the margination of the chromatin material. But here these three infections are there, but the clinical vignette can also suggest that these patients also have immunocompromised state. It means that immune system is not functioning properly. But the herpes infection can also occur in immunocompetent patients whose immune system is functioning properly. Okay. The last type of esophagitis is eosinophilic. We have discussed about chemical, the reflux, the infective. Last is the eosinophilic esophagitis. The name is mentioning its description that why it's occur. Eosinophils. Eosinophils are hallmark white blood cells for allergy and inflammation conditions. It's due to any allergy. There are many hypotheses given for this kind of esophagitis, but most common is the allergy. It can be due to pollens or soya or any kind of allergy. But most important thing here is that eosinophils number. Per high power field, we can see 15 eosinophils. Eosinophils are 15 in number as per high power field. And in the microscopic examination, we can see these orange cells. I'm demarcating them. These are eosinophils. In histology, mostly purple, pink, and bluish cells are present, but eosinophils are orange in color. And in esophagitis, there are a lot of them, 15 eosinophils per high power field. And grossly, we can see that there are circular rings inside the esophagus. It resembles the cat esophagus, okay? It is resembling the cat's esophagus, and due to this reason, this esophagus is known as the feline esophagus. The treatment for this kind of esophagitis is that to remove that allergen, just to remove that allergen, and the esophagus will return to the normal state. This was for today, and in the next lecture we will discuss about the Barrett's esophagus and some other diseases related to